This is Dr. Lori Garner from Nicholls State University, and I will be lecturing on drugs affecting the hematological system for Nursing 517 Advanced Pharmacology. The objectives of this lecture are to discuss the pharmacodynamics and the pharmacokinetics of drugs affecting the hematological system, and describe pharmacotherapeutics of drugs affecting the hematological system. Multiple classes of medications affect the hematological system, including anticoagulants and antiplatelet drugs that affect clotting. There are hemopoietic growth factors and supplements such as iron, folic acid, and B12 that affect the system. In this lecture, I will discuss anticoagulants and antiplatelets, hematopoietic growth factors, just briefly, iron preparations, folic acid, vitamin B12, and biologics for hemophilia. Although the exact details of the clotting mechanisms are not fully understood, it's generally accepted that clotting occurs when several circulating proteins interact in a cascading series of limited proteolytic actions. And if you take a look at the clotting mechanism table before you, it shows tissue factor pathway inhibitor, starting with factor 7 inhibiting the oral anticoagulant drugs like warfarin plus a tissue factor, moving over to the tissue factor pathway inhibitor, and following its way down. You are not responsible for knowing this table for the exam, but I do want you to familiarize yourself with it. So what are the pharmacodynamics? Warfarin is well absorbed orally, highly protein bound, metabolized by CYP1A2 and CYP2C9. It is excreted in urine, and the half-life is about 3 to 4 days. Anticoagulants and antiplatelets inhibit synthesis of vitamin K-dependent clotting factors and prothrombin. Heparin, including low molecular weight heparin drugs. Heparin is given IV or sub-Q. Heparin is extensively protein bound, and low molecular weight heparin drugs are not protein bound. They're metabolized by the liver and eliminated by the kidneys. So aspirin inhibits cycloogenase pathway and it interferes with platelet aggregation. Plavix or clopidogrel reduces platelet aggregation by inhibiting adenosine diphosphate or the ADP pathway. Then there's Brilinta, which reversibly interacts with platelets P2Y12 ADP receptor to prevent platelet activation. And then there's Vorapaxar, that's a protease activated receptor 1 or PAR1 antagonist. It inhibits thrombin-induced and thrombin receptor agonist peptide-induced platelet aggregation. It is taken with aspirin or clopidogrel. I'm probably saying that wrong. Thrombin receptor agonist peptide-induced platelet aggregation. Some precautions and contraindications of heparin and low molecular weight heparin. For heparin, avoid use in advanced hepatic or renal disease. Caution in pregnancy, you should weigh the risks versus the benefits. For low molecular weight heparin, is contraindicated in uncontrolled bleeding. Use cautiously in renal impairment, untreated hypertension, retinopathy, and liver disease. It is not used for thromboprophylaxis with mechanical prosthetic heart valves. All anticoagulants are contraindicated in patients who are hypersensitive to the drug, are actively bleeding, or who have hemophilia, thrombocytopenia, severe hypertension, intracranial hemorrhage, ineffective endocarditis, active TB, ulcerative lesions of the GI tract. Heparins are metabolized by the liver. The secondary site of metabolism may be the kidney. They may be used in patients who are actively bleeding to treat DIC. Okay, so that is for disseminated intravascular coagulation. That's the only time. Low molecular weight heparin are contraindicated for patients with allergies to pork, sulfites, or benzyl alcohol, for patients with uncontrolled bleeding, and in patients who have antiplatelet antibodies. Renal impairment requires cautious use, so you have to be very careful. It can be used, but use with caution. Caution is also indicated for untreated hypertension and retinopathy, whether it's hypertensive or diabetic. Low molecular weight heparins do not cross the placenta and do not cause any kind of teratogenesis, or they're not teratogenic to the fetus, or fetal bleeding. Enoxaparin was previously labeled as a category B when we still use those categories, which means it was pretty much safe and there were rare reports of any congenital malformations. Some precautions and contraindications with warfarin: caution in hepatic dysfunction, hypermetabolic states, hyperthyroidism in older adults. Also, caution with severe cognitive impairment, a history of falls, uncontrolled hypertension or non-adherence, and warfarin should be avoided during pregnancy. Warfarin does cross the placenta and can cause hemorrhagic disorders in the fetus and serious birth defects. Direct factor XA inhibitor, there is a box warning. Premature discontinuation may lead to a thrombotic event. Some examples of that would be rivaroxaban, apixaban, and edoxaban. Some precautions with aspirin: there is a cross sensitivity with NSAIDs. Caution in liver disease or vitamin K deficiency. Avoid use after 20 weeks gestation of pregnancy. With ticlopidine, and clopidogrel, avoid in hepatic disease and GI ulcers, and use in caution in older adults. Some adverse drug reactions for those patients taking heparin include thrombocytopenia and anemia. Heparin may cause life-threatening bleeding, may cause pain at the injection site. If needed, the antidote is protamine sulfate, and that should be a review. Warfarin may cause hemorrhagic skin necrosis. Bleeding antidote for warfarin is vitamin K. Some drug interactions. Heparin does interact with cephalosporins and penicillins, antiplatelets, and dextran. Warfarin, second and third generation cephalosporins and high doses of penicillins, many drug interactions. Vitamin K has an antagonistic interaction. Anticoagulants, antiplatelets, NSAIDs, and antifungals. There's many drug interactions, so this is not something that you'll have to memorize. But grapefruit, remember we had a discussion before in another lecture on grapefruit. There is evidence indicates that these drugs probably potentiate the action with increased risk of bleeding. So you want your patient to avoid consuming grapefruit juice or grapefruit. Prevention and treatment of thromboembolism. Parenteral anticoagulation with low molecular weight heparin or sub-Q fondaparinux, followed by oral anticoagulation therapy. A cancer patient with DVT, oral XA inhibitor for initial and long-term treatment instead of warfarin or low molecular weight heparin. Warfarin is second-line drugs for systemic thrombosis, venous thromboembolism. Dose to maintain international normalized ratio or INR between 2 and 3. The beginning dose of warfarin is 2.5 to 7.5 milligrams daily. Consider lower doses if the patient is older than 75, if they have multiple comorbidities, poor nutrition, if they have an elevated INR when off of warfarin, if they have elevated liver enzymes, or there's changes to their thyroid status. If a patient has mitral valve disease, the target INR for warfarin is 2.5. Some long-term options for someone who's had an ischemic stroke. Aspirin, 160 to 325 milligrams within 48 hours would be given right away. And then long-term options would be Plavix, 100 milligrams of silostazol twice daily, 75 to 100 milligrams of aspirin. You can use a combination of aspirin and extended release diamole. A history of ischemic stroke or TIA with AFib, prescribe anticoagulants with 150 milligrams of dabigatran twice daily. For recurrent embolism and prosthetic heart valves, warfarin is the drug of choice. The target INR depends on the type of valve. With more risk factors, you may add 75 to 100 milligrams of aspirin. Treatment is continued indefinitely, so these patients will always be on medication. For pregnancy, use one of 3 regimens, either low molecular weight heparin twice daily during pregnancy. They can have sub-Q heparin every 12 hours. They can have sub-Q heparin or low molecular weight heparin until the 13th week, and then warfarin until close to delivery. For prevention of a myocardial infarction, aspirin, 75 to 100 milligrams, and that's for patients that are 40 to 70-year-olds without any symptomatic cardiovascular disease. Aspirin, 75 to 100 milligrams, or Plavix, 75 daily. Dual antiplatelet therapy for acute coronary syndrome with percutaneous coronary intervention with or without stent placement. For preventing postoperative thromboembolism, low molecular weight heparin or low dose heparin is used for moderate risk major general surgery, higher risk patients who have had major general surgery, major vascular surgery, major gynecological surgery, major urological procedures, bariatric surgery, and a hip fracture repaired. All hospitals are required by Joint Commission to have a formal, active strategy to prevent venous thrombosis. The American Society of Hematology, which is ASH, recommends the use of low molecular weight heparin or low dose heparin as thromboprophylaxis in the following surgical procedures, which I have already named. For orthopedic procedures or surgeries, ASH guidelines recommend using direct acting anticoagulants over low molecular weight heparin in patients with hip or knee replacement for 14 days. The length of treatment is determined by the type of surgery, ranging from a single dose for minor procedures to 10 days for most orthopedic procedures to 28 days in high-risk patients undergoing major gynecological surgery and patients having major surgery for cancer. Preoperative therapy of patients on warfarin or antiplatelet therapy. If they are on warfarin, you're going to hold that for at least 5 days before surgery and resume within 24 hours after. If they're on warfarin to prevent thromboembolism, they may require parenteral anticoagulation perioperatively. If low bleeding risk procedures, they can remain on warfarin. Direct-acting oral anticoagulants stop 2 days before surgery, then resume 24 hours after procedure or 48 to 72 hours with increased bleeding risk. Plavix is stopped 5 days before surgery. And ticagrelor is stopped 3 to 5 days before surgery. If your patient is on warfarin, INR, check daily until stable, then 2 or 3 times weekly for 1 to 2 weeks, then less often. You can check it every 3 months. Usually those patients are going to a PT-INR clinic and having this monitored. Adjust the dose based on INR and administer vitamin K if required. Again, most patients that are on warfarin newly starting are definitely going to PT-INR clinics, Coumadin clinics. For heparin, a PTT blood test, the goal is 1.5 to 2.5 times the control. Platelet count and hematocrit every 2 or 3 days initially, and monitor for thrombocytopenia. If thrombocytopenia, it tends to occur about the 4th day and it resolves despite continued heparin therapy. Thrombocytopenia is severe enough to require discontinuing therapy, may occur about the 8th day of therapy. After this time, periodic testing of platelets and hematocrit levels and testing for occult blood in the stool are done during the course of heparin therapy, regardless of the route of administration. Low doses of sub-Q heparin, about 5,000 units twice a day, does not require monitoring because this regimen does not prolong the PTT. For low molecular weight heparins, monitor platelet and hematocrit levels. Anti-factor XA assay, monitor in pregnant patients. For ticlopidine, I don't know if I'm saying that right. Neutropenia and thrombocytopenia. Perform a complete blood count and white blood cell differential counts every 2 weeks from the second week to the end of the third month of therapy. Educate your patient on warfarin, the different color-coded tablets, on sub-Q injections, and knowledge of foods high in vitamin K. Drug interactions, so they need to wear a bracelet that they are on a blood thinner. They need to take care to avoid bleeding, report any signs of bleeding, and you should not be giving this to them if they are pregnant, so they need to avoid in pregnancy. Any bleeding that does not stop within 5 minutes, they need to notify the healthcare provider. If they have nosebleeds or bleeding gums, any red or pink tinged urine, faintness or weakness, any headaches, stomach pain, skin rash or unusual bleeding, or red, black, or tarry stools or diarrhea. Antiplatelets, talk to them about daily aspirin with a full glass of water and take it with food. Cyclopidine, take with a full glass of water or take with food. Adverse drug reactions, talk to them about aspirin toxicity. Also with cyclopidine, they need decreased white blood cell count. Talk to them about that, the risk of infection and the effects on their liver, and to monitor for any unusual bleeding. Enteric-coated forms of aspirin are available and are usually better tolerated by some patients. Make sure they understand that if they are taking enteric-coated tablets, they don't crush or chew them. And this is a little bit about hematopoietic growth factors, which you can read up on in your chapter, and you can also view the slides. This chart is available for you in your book. We'll talk about iron preparations. Iron preparations build serum iron and iron storage in the body. Enhance absorption if iron stores are low. Ferrous form absorb more readily. Food can affect absorption. It's eliminated via shedding of GI mucosal cells with small losses in the urine, sweat, and bile. Some precautions and contraindications include hemochromatosis and hemolytic anemia, which we will talk about in another lecture. Adverse drug reactions include constipation, nausea, vomiting, and acute toxicity is possible, especially in children. Drug interactions include levodopa and quinolones, and there is a competition for absorption when the patient is taking antacids or cimetidine. Iron preparations are used for iron deficiency anemia. Treatment is for 3 to 4 months after hemoglobin and hematocrit return to normal. Adults about 150 to 300 elemental iron daily in 2 to 3 divided doses. You will monitor a retic count 7 to 10 days after starting therapy, hemoglobin at 2 weeks, then based on the individual's risk. Patients should be educated about prevention and consuming an adequate intake of iron in their diet. Take on an empty stomach if tolerated. Take with vitamin C to enhance absorption, so it's good if they take it with orange juice. Avoid taking with dairy products, calcium, and antacids. Iron preparations may cause constipation. They can have acute iron toxicity with overdose, so make sure that this is kept away from children. They should contact poison control immediately if an overdose is suspected. Folic acid deficiency is usually caused by poor dietary intake of green vegetables, impaired absorption, and there is an increased demand of folic acid during pregnancy, and folic acid can be impaired when taking methotrexate. It can be absorbed oral, IM, or sub-Q. It is metabolized by the liver and excreted in the urine and feces. Folic acid is used for anemia caused by folic acid deficiency and prevention of folic acid deficiency. And these are the doses which you do not have to memorize. Vitamin B12. Vitamin B12 usually happens from poor intake, like if patients are vegans or vegetarians. Impaired absorption caused by lack of the intrinsic factor, diseases of the ileum, gastrectomies, and bariatric surgeries. Vitamin B12 is available IM, sub-Q, or intranasal. They're all well absorbed. It is stored in the liver and excreted in the urine. And here are the doses. Here's some biologics for hemophilia. Vitamin B12 is used for pernicious anemia. Multiple classes of medications affect the hematological system, including anticoagulants and antiplatelet drugs that affect clotting, hematopoietic growth factors, and supplements iron, folic acid, and B12. Okay, knowledge check. So you will have to rely on reading your chapter for drugs affecting the hematologic system. You will see what I will be testing you on the blueprint. However, if you are familiar with the knowledge check, you should do very well. Which of the following has a box warning that premature discontinuation of drug therapy may lead to thrombotic events? It is either Axiban, warfarin, aspirin, or none of the above. The antidote for heparin is which of the following? Either betrixaban, folate, vitamin K, or protamine sulfate. And that is the end. Review the chapter for clarification. That is the end of this lecture.